Welcome to the Boston Structural Heart course. In this presentation, we are going to go over the echocardiographic examination of a mitral valve with degenerative disease that is being considered for suitability for edge-to-edge repair. The first and foremost question to answer is that we do mitral valve examination for repair all the time in patients selected for open cardiac surgery. How is this exam for edge-to-edge repair any different for the exam that is being performed for surgical open mitral valve repair? Well, if you look at it critically, there are numerous differences, numerous very important differences. First of all, the examination for a surgical mitral valve repair is performed immediately after induction of general anesthesia in the precardiac pulmonary bypass phase. We don't perform any examination while the repair is being performed, while the patient is on cardiopulmonary bypass with the heart is paralyzed, flaccid, and the mitral valve is static. And then another examination is performed after the patient separates from cardiopulmonary bypass. Therefore, the examination and the actual repair are temporally separated. And above all, if something was to go wrong, repair was not to the expectations of the surgeon, you can always go back and try to either re-repair or provide a definitive solution in the form of replacement of the mitral valve in the same setting. Now, contrary to that, examination for an edge-to-edge repair is performed immediately after induction of general anesthesia, but it continues in a point-of-care fashion while the valve is being repaired. Therefore, procedural guidance is provided for the mitral valve repair that is being performed percutaneously, temporarily in the same setting as the exam is being performed. Therefore, the examination and the procedural guidance are being performed and provided in the same setting and temporarily at the same location. Secondly, the most important thing is, while there is limited assessment, while the clip is still attached and not released from the delivery sheath, once it is released, it is a one-way street, which means you cannot go back, take the clip down, and try to re-repair it. Which means the qualitative and quantitative assessment of mitral valve for an edge-to-edge repair has to be performed with a far greater degree of precision that you'd be performing for a surgical open mitral valve repair, using both 2D and 3-dimensional qualitative information, as well as Doppler-derived data regarding color flow, pulse wave, and continuous wave Doppler to avoid, first of all, to diagnose the presence of any stenosis, to avoid any residual stenosis after the deployment of the device. So, in the first phase of this presentation, we are going to go over a few general principles for the assessment of mitral valve for repair that are applicable to both the open surgical as well as the edge-to-edge repair. So let's get to this presentation. Now let's go over the general assessment of mitral valve with degenerative disease for assessment of suitability for repair, whether be it open surgical repair or be it percutaneous edge-to-edge repair. The basic principles are the same. Where there are specifics related to the edge-to-edge repair, we will make specific recommendations in that regard. So the key part of this examination is that this examination has to be an algorithmic approach, which means you should know in a stepwise fashion what you need to do and not just simple random acquisition of images from one plane to another. So the conduct of an examination for edge-to-edge repair has to be methodical, has to be objective, and of course it has to be time efficient to provide a recommendation for the proceduralist regarding the suitability, the success, or the failure, or any other factors related to edge-to-edge repair. So what does mean by being methodical? And that means we have to have a qualitative aspect of it, which means visual qualitative assessment of the leaflets, the mobility, or the lack of it. Quantitative aspects, which relate to quantification of area using Doppler means, using multiplanar reformatting to planimeter the valve, as well as using continuous pulse wave and color flow Doppler to quantify the mitral regurgitation and assess the hemodynamics of the valve. Now, the objective, it has to be in this sense the exam has to be designed to answer a very specific question. Is this valve repairable by an edge-to-edge repair technique? And when it has been repaired, is that a suitable repair to be deemed successful? So these are the two most important concepts of an objective intraoperative echocardiographic examination. But the key part of this mitral valve examination, it is not just the leaflets. It has to be in the context of mitral valve apparatus that consists of the mitral annulus, the leaflets, the chordae tendineae, the papillary muscles, as well as the adjoining left atrium and the left ventricular myocardium. So it's a composite of multiple structures. Now, as relates to the mitral valve examination, we've conformed, and universally, the Carpentier's classification that is displayed in a three-dimensional surgical view of the mitral valve is the one that is followed, which means aortic valve is placed at the 12 o'clock position, A1, P1 is the anterolateral commissure, A3, P3 is the posteromedial commissure, and A2, P2 conforms to the central portion. So now, the peri-procedural 3D images that we generate have to conform to this orientation of the structures that adjoin the mitral valve when it relates to procedural guidance, because you have to follow a common nomenclature. So technically, the proceduralist should follow the echocardiographic display, which is based on the Carpentier classification, left atrial en face view of the mitral valve, the aortic valve at 12 o'clock, left atrial appendage at 9 o'clock, tricuspid at about 3 o'clock, and the coronary sinus in the atrioventricular groove posteriorly. A1, A2, A3, P1, P2, P3, that is anterolateral to posteromedial commissure of the mitral valve. So my method relates to examination of surgical valves. The algorithmic approach is based on these following steps. These have already been published also. However, it starts with first exclusion of contraindications, diagnosis and quantification of dysfunction, identifying the mechanism of dysfunction, what the pathophysiology of the dysfunction that led to that specific mechanism, then predictors of repair failure, which relate more to surgical valve as opposed to the edge-to-edge repair, and the rest of this stuff relates to surgical repair, except for this post-repair assessment, which involves essentially exclusion of significant regurgitation or significant residual stenosis after the procedure. So let's go over each one of them that relates to edge-to-edge repair. First and foremost, we must exclude contraindications that preclude us most definitely from doing any mitral valve repair. So here are most important contraindications to mitral valve repair, which means number one and foremost is stenosis. After any repair attempt, there's an immediate and a long-term reduction in mitral valve area, which means if the valve area is already in the range of mild or moderate stenosis, is going to become severe and even more critical down the line. So therefore, presence of any degree of stenosis is considered a contraindication for either surgical or an edge-to-edge repair. The presence of active infection, severe mitral annular calcification. Now this becomes a little bit more, tricky and subjective. Same goes for severe mitral annular dilation with significant flail gap in the leaflets that we'll discuss further down in the presentation. And lastly, emergency surgery. Now that's another indication which is becoming less absolute, because we have in our medical center performed a few emergency transcatheter edge-to-edge mitral valve repairs. And majority of them with tremendous success. The patients being extubated off inotropes. These are patients who were either in whom the surgery was contraindicated or were prohibitive risk for surgery. So then comes the qualitative assessment. First and foremost is there any dysfunction? Since stenosis is a contraindication, the dysfunction is essentially the regurgitation. So the first and foremost is there any mitral regurgitation? That's the first question to answer, because if there's none, then we are done, So the next thing to answer after that the qualitative assessment is confirm the presence of MR. Now that's usually done with color flow Doppler. That's although there are other means of doing that, but this is we try to do a quantitative or a semi-quantitative assessment. Well, for whatever reason, we are heavily biased in our medical center towards using vena contracta and not the proximal isovelocity surface area method, because while it's a little bit more complicated by the nature of the disease and the more assumptions that are built into the geometry and calculations, the harder it becomes to be accurate and be specific. So therefore, we are heavily biased towards measuring the vena contracta and quantifying the regurgitation based on the vena contracta severity. For a vena contracta measurement to be valid, 3 of these things have to be demonstrated on the same jet, which means flow convergence, contraction, and finally for flow expansion have to be seen in the same frame for the vena contracta to be measured accurately. And therefore, we must make an attempt to demonstrate all 3 components of a jet And we certainly make a lot of mistakes when when we're not demonstrating all the same components at the same frame. For example, on the left, as you can see, we can see some evidence of regurgitation, but we're not seeing all three components of regurgitation jet in the same frame. However, if you move on to the right side, when the probe has been appropriately adjusted, you can see that you can truly visualize the flow convergence, the flow contraction, and finally the jet expansion, which is an eccentric regurgitation jet. And once we have identified the three components of the jet, then we must zoom on it to correctly, re-identify and make our linear measures, because the more zoom we apply on the image, the bigger the image is, the less the error, and the smaller the image, the linear error tends to be magnified. So whenever we use Wiener contractor, we try to demonstrate all three components of the jet, use the zoom function, and then we measure the Wiener contractor. We can also use simultaneous orthogonal plane imaging, particularly if it is possible to do an R-wave gated acquisition, to define and quantify the Wiener contractor with a degree of precision, rather than simply using the monoplane examination of the mitral valve that we'll address in the later part of this presentation. However, this makes it much more accurate if you're using the simultaneous orthogonal plane imaging of the mitral valve. Now, flail leaflet, we could also implies that there is severe regurgitation, and we also try to demonstrate the waves, which means the reversal of flow in the pulmonary veins, because sometimes visual quantification of the reduction in regurgitation cannot be totally or solely relied on, particularly when it is torrential of 5+ mitral regurgitation. In that case, demonstration of lack of pulmonary venous inflow reversal, which was present before the clip was applied, provides a very accurate and very objective method of the value of the edge-to-edge repair, which did very well. Same goes for looking at the direction of the jet, which implies if it's a central regurgitation jet, that implies it's a bileaflet disease and not necessarily good news. A regurgitation jet that is eccentric implies a single leaflet disease, and its directionality should be noted because that implies which specific leaflet is involved. Lastly, we should try our best to use three-dimensional echocardiography for quantification and visualization of eccentric regurgitation jets, because flattening of jet on the wall can make it spread out, and in two-dimensional imaging using color flow Doppler can lead to significant underestimation of the jet. So recap of the assessment, we first of all diagnose the presence of MR. Secondly, we quantify MR semi-objectively. And the third step is mechanism. Now, this is all based on Carpentier classification. We all know that. I'm not going to go into the detail, which implies type 1 when the leaflet motion is normal or there's a hole in the leaflet and annular dilation. Type 2 when there's degenerative disease, when excessive motion. This is what we are concerned about. And finally, type 3A and B, which relates to ischemic and rheumatic mitral valve restriction. For example, as you can see, this patient referred for a Mitra clip with the misdiagnosis of flail leaflet. However, this was a perforation. On further examination, the case was cancelled. Same goes for the excessive motion. We have to quantify what kind of specific excessive motion it is. It is billowing, which means only the central portion is coming into the left atrium, or it is prolapse when the point of coaptation is beyond the plane of the mitral annulus, and lastly is flail, which implies torn chordae, and the undersurface of the leaflet is exposed to the left atrium, is referred to as flail. So therefore, you can have multiple prolapsing segments and you can have multiple flail segments. That distinction is very critical because that builds into the clip deployment strategy, and that's the site where you want to deploy the clip. For example, this is a flail leaflet, and these are multiple prolapsing segments, but none of them is flailing because the undersurface of the leaflet is not exposed to the left atrium. Leaflet tethering in mitral regurgitation is not something that we'll discuss with, but exclusion is important in saying that certain segments may be prolapsing and flailing while the others may be restricted, and an important distinction that has to be made. So to recap, step 1 of an assessment of mitral valve for edge-to-edge repair is to first of all diagnose dysfunction, that is the presence of MR. Secondly is quantification of dysfunction, that is quantification of MR, that we use vena contracta. And the third is etiology, which includes the mechanism as in the pathophysiology that led to that dysfunction. Now, the pre-procedure planning in the first few years of MitraClip was heavily based on the Everest trial, which had very tightly controlled criteria of selecting patients for mitral regurgitation. For example, regurgitation jet should be non-commissural because that's a very hard place to deploy a clip because of presence of a lot of chordae tendineae. Mitral valve area had to be more than 4, minimal calcification in the grasping area, no leaflet clefts, and finally, flail width, as we'll see in the few graphics, had to be less than 15 millimeters of mercury. But this brings us into mitral valve quantification, and that was, again, as I said in the past, was based heavily on the criteria of the Everest trial, which is since over, and now the utility and efficacy of mitral valve edge-to-edge repair is established that these indications are expanding, and there are very few contraindications doing this one. The key eligibility criteria for the Everest 1 trial were the jet had to be coming up in the center of the valve, and for functional mitral regurgitation, the coaptation length had to be at least 2 millimeters. That is the point of the zone of apposition between the two leaflets. And lastly, the coaptation depth as less than 11 millimeters of mercury. So if you look at this was what the valve was looked at, which means you looked at the length of the AP diameter of the valve. This was the tenting height. This was zone of coaptation of the coaptation length. And this was the tenting height. Now keep going on this one. This was referred to as the flail gap, which means the difference in the distance between the leaflet that wasn't flailing and the maximal point of flail. And this was referred to as the flail width, which means the wider the flail width, which implies that not that it is not amenable to edge-to-edge repair, but means that you may have to deploy more than one device over time. Whereas examination of the mitral valve, quantification of regurgitation, and assessment of a repaired valve after an edge-to-edge repair are being addressed in different lectures. But for specific to degenerative heart disease, the most important point besides quantification of the mitral regurgitation is the location of the mitral regurgitation jet, and specifically so in relation to the Carpentier classification, anterolateral, posteromedial, or smack in the middle of the mitral valve. For this reason, there are a few tricks in examining the mitral valve that relates to a monoplane two-dimensional examination as well as a monoplane three-dimensional examination that is also referred to as a high frame rate examination, and particularly so the importance of the transcommissural view, which we will address in the next case presentation that I've specifically prepared along with Dr. Aidan Sharkey as a panelist for this presentation. So the case history is that we have a patient who is 78-year-old male with history of coronary artery disease and multiple coronary stents placed in the last 5 or 7 years. Recently he had a history of numerous episodes of heart failure. He had a detailed workup at the hospital that revealed severe functional mitral regurgitation. Considering all his comorbidities, he was considered prohibitive risk for surgery and was scheduled to undergo MitraClip. We'll keep the history and physical examination short so they can focus on the problem at hand, that was the intraoperative or the periprocedural transesophageal echo examination. So these are the first or the 3 initial images that we took in this patient. This shows a mid-esophageal four-chamber, a little close-up of the valve, and a mitral regurgitation jet which demonstrates it's going a little bit more posteriorly directed. As you can see, there's this strut cord in this anterior leaflet, which is sort of attached close to the margin of the anterior leaflet. This was of very serious concern to us because we thought that if we were to do something, it might get entangled in this cord and at the same time cause the cord to rupture and have a flail anterior leaflet. So, Aidan, what do you think? Would you be concerned about the position of this strut cord, and would you sort of have a different clip strategy, which means would you choose an extra wide clip or extra, the not so wide clips for this one?
Yes, I mean, the cord is definitely an issue because you don't want to end up with a flail cord, as you said was the kind of the worry here. So I think in this situation, having the ability to grasp each leaflet separately, might be an advantage. And having a wider clip as well might be an advantage as well. Yeah.
And also, if you see that the posterior leaflet is significantly retracted and kind of curled over, This means that a smaller clip may not be able to get under it physically, and you may have to kind of bunch it up with a larger clip. So there was a little challenge in its anatomy as we look at it. Do you agree with that?
Yeah. I mean, it's very retracted there, so I can definitely see problems with the shorter clip of grasping that leaflet, which again, being able to individually grasp the leaflets might be of benefit, with the newer devices.
Okay. So what is being discussed is that the morphology of the leaflets, specifically the lengths and the degree of retraction of the leaflets, can be used to select the type of clip to be used in this clinical operation. For example, the G4NT and G4NTW are 4 millimeters and 6 millimeters wider than, but at the same time, the newer versions, that is G4XT and XTW, have a larger and a longer length of the arm. So therefore, longer leaflets can be grasped, and at the same time, retracted leaflets can also be easily grasped in these larger clips. Since it was already established that the patient had severe mitral regurgitation, our initial exam was focused in localizing the point of origin of the mitral regurgitation jet. Looking at this transcommissural view in which we can see the posteromedial and the anterolateral commissures at the same time, it appears that the larger area of flow convergence is between the A2 scallop and the P1 scallop on the right side, which implies that the majority of the regurgitation is coming from the lateral side of A2, P2, or on the anterolateral commissure. What do you think, Aidan?
Yeah, I mean, looking at that video on the right, you can definitely see, the Pisa formation there is right at the kind of the P3 scallop area. So, I mean, that's where I think the main or the first target should be, and probably where the first clip should be directed towards.
The learning point of this activity is that for a comprehensive interrogation of an MR jet, an area of flow convergence, flow contraction, and flow expansion has to be seen in the same frame. In the absence of simultaneous visualization of all these three components, neither the origin nor the severity of the MR jet can be conclusively diagnosed, as is the case with the jet seen above the posteromedial commissure in this video loop. Next, we perform the monoplane examination of the mitral valve that consists of progressive advancement of the TE probe with scan plane at 0 degrees with and without color flow Doppler from the A1P1 to A2P2 and finally A3P3 scallops. Interestingly, it shows that most MR is actually coming from the A2P2 and A3P3 scallops, contrary to what we found in the transcommissural view. Aidan, what do you think?
Yeah, no, I think you can see a nice Pisa formation there. So I think we're definitely beginning to see, the origin of the most significant regurgitant jet at this location.
So based on the monoplane examination as well as the transcommissural view and the location of the flow convergence, contraction, and expansion, it can be safely concluded that the jet is originating from the posteromedial scallop of the valve, the one that you're looking on this graphic, and highlighted by this yellow square. We demonstrate the precise location of the regurgitation jet and the possible location of the first clip deployment. However, as much as I'm a fan of the transcommissural view, as this graphic will demonstrate that it is easily possible to misidentify the scallops even on the transcommissural view based on the scan plane rotation, the variations with respiration of the cardiac silhouette, as well as translation motion of the heart. So it's not entirely a done deal when you see something on the transcommissural view. The first teaching point from this activity is the utility of the monoplane examination of the mitral valve, in which the transesophageal echo probe is gradually advanced in the esophagus at 0 degree scan rotation from the anterolateral commissure between A1 and P1 to A2 and P2 and progressively to A3, P3 scallops of the mitral valve and interrogation of the posteromedial commissure. It removes the ambiguity obtained with oblique views and accounts for sometimes the translation motion of the heart as well as respiratory variation. Secondly, while we heavily rely on the transcommissural view to diagnose and identify the precise location of the regurgitation jet, it is obvious that because of the translation or motion of the heart or slight motion of the probe from left to right, there can be significant variation in the scallops that are displayed, as was the case in this specific situation. Based on the available information, particularly the monoplane examination, it can be safely concluded that the major part of the regurgitation jet starts from the medial side of the A2-P2 scallop and between the A3 and P3 scallops.
Yeah. And I mean, just going back to your point, I mean, when we look at a 2D examination, we make a lot of assumptions that we're in the correct plane. So, I mean, I think not, I think this all needs to be confirmed, and this is where the value of 3D comes in to precisely locate. So I think that would be the next step, is to do a 3D examination of this on this patient.
Next, we obtain a 3D en-face view of the mitral valve with color flow Doppler information. On the left, the video shows the entire extent of the regurgitation jet from the line of coaptation through the entire left atrium, whereas the graphic on the right, the grayscale has been maintained where the color flow Doppler information has been cropped down through the origin of the jet from the line of coaptation to show its broad nature and its precise location of its largest extent. In the middle is a graphic for visual feedback to identify the precise location of the MR jet. Based on the available information, it can be safely stated that majority of the regurgitation is coming from the middle of the valve between A2, P2, and then posteromedial commissure, that is A3 and P3, and there's a small regurgitation jet between A1 and P1. And the apparent contradictory information was obtained because of possibly an oblique section of the valve which made it sound like most of the regurgitation was coming from A1 and P1. What do you think, Aidan?
Yeah, no, I would agree with that. And I mean, the image on the right, you can see the real elliptical shape of the jet, which again, is in keeping with, ischemic regurgitation. So, that image on the right really highlights it's a broad-based jet, elliptical in shape, coming from, the medial aspect of A2-P2 into A2-P3.
There are three important learning points from this exercise. Number one, there should always be a backup imaging plan when suboptimal imaging is encountered in a patient undergoing a percutaneous structural heart disease intervention. Number two, whereas three-dimensional imaging is ideal, two-dimensional imaging can provide valuable insights into precisely locating structural heart disease derangements, particularly so in mitral valve. And number three, the echocardiographer should have a detailed and a thorough knowledge of cardiac anatomy in its display to customize the echo exam to the anatomical peculiarities and to localize structural derangements with a degree of precision, as was the case in this patient. So in the final analysis, examination of a mitral valve with degenerative disease for transcatheter edge-to-edge repair is a challenging undertaking. It is significantly different from a surgical examination of the mitral valve that is performed in the pre-cardiopulmonary bypass period, because it is performed and interpreted in real time, with procedural guidance being provided simultaneously with the motion of devices in the intracardiac space. The repair is being provided with real-time three-dimensional echocardiographic guidance with consequences for the interventionalists for any piece of information that is furnished to them. But most importantly, this exam is important in providing a precise information, because once deployed, the device to do the edge-to-edge repair cannot be retrieved back. So it's a one-way street. Having said that, besides a comprehensive examination of the mitral valve, the most important thing is the quantification of MR, as well as the site and location of the origin of the regurgitation jet, because that is one piece of information that is most critical, and that is the site of deployment of the clipping device in relation to the origin of the jet. And so you have to have a very precise location. Whereas we have become used to using three-dimensional echocardiography, a detailed knowledge of two-dimensional echocardiography is very important, because certain aspects of two-dimensional echo, such as the monoplane examination as well as transcommissural view, are extremely important in localizing the origin of the mitral regurgitation jet, particularly so in patients with arrhythmias and irregular heartbeats, in which a high frame rate and a high line density three-dimensional examination of the mitral valve cannot be performed because of irregular rhythm, and so that R-wave gated acquisition cannot be performed. Therefore, while three-dimensional echocardiography has made these interventional devices being possible, these percutaneous interventions possible, the value of two-dimensional echocardiography has to be appreciated, because that is sometimes one of the most important tricks that can save the day and provide you in guidance that sometimes three-dimensional imaging falls short of. So therefore, the most important thing is the quantification of regurgitation, the location of regurgitation, and remember the value of the transcommissural view as well as the monoplane examination of the mitral valve from the anterolateral to the posteromedial commissure that is specific for transcatheter edge-to-edge repair. Thank you very much.